It is my pleasure to announce our panel of experts from the Mazzoni Center. To my left here is Judy Morrissey, and Judy is a clinical social worker, and she is the director of Mazzoni Center's Open Door Counseling Program. Her experience and background includes a range of inpatient and outpatient experiences in LGBT settings. She is particularly interested in trauma, addiction treatment, and co-occurring disorders. And then to Judy's left, we have Rand Faulkner, and Rand is a clinical social worker at Mazzoni Center's Open Door Counseling Program, and he specializes primarily in struggles with substance abuse and depression, substance abuse dependence, as well as trauma, anxiety, depression, and a host of other concerns figure heavily into his work. So please give us a round of applause for Judy and Rand. They will speak briefly, and then we'll open it up to Q&A.
We're experts, Judy.
Well, I was just going to say, Terry was very flattering in her introduction, but I have to say the experts really are in the room here. We're just going to talk about our experience and really try to draw in a little bit more specific to LGBT issues. So wanted to talk and just kind of give some context. By the year 2030, 20% of the population will be over 65. By 2050, 1 in 5 people will be over 65. And we're talking, in terms of LGBT, 500,000 LGBT people turn 50 every year. So quite a significant number. And although older adults are expected to be healthier nowadays than in the past, 80% of us will have at least one chronic condition, and 62% of us will have at least 2 or more conditions. And so, you know, it's something we need to think about. So with LGBT older adults, there are some general health disparities and mental health disparities that we should be aware of. We're probably one of the least understood groups because it's difficult to do research on groups that sometimes, and people that sometimes we're not out to our doctors or our providers, and so they aren't able to tell, you know, what our issues are succinctly. Many LGBT older folks have spent a lifetime concealing identity. So it's difficult to say, well, you know, go to your doctor and tell your doctor that you're gay or that you're lesbian. So some of the specific health disparities, LGBT older adults especially, are less likely to have insurance, are more likely to delay in seeking medical care, and are more likely to go to the ER for medical care. And so that lends to a very sporadic and choppy type of treatment. Lesbians and bi women are more likely to be overweight and less likely to seek preventative care for different services, especially related to cancer. And gay men, especially men of color, are at higher rates for HIV and STD. And as a whole, we have higher rates of alcohol use, drug use, and tobacco use in our communities. So in terms of mental health specific disparities, LGBT folks are more likely to experience psychological stress. And trans adults are more likely to experience suicidal ideation. And again, higher rates of alcohol use, tobacco use, and issues of low self-esteem. So we wanted to talk today a little bit about our experience in working with LGBT older adults, specific issues related to aging mind, but also general psychological issues that people present with. So.
Hello, everyone. So really, we're going to be talking about problems that we all are familiar with, that we've experienced at some point in our life, but they're aggravated in some way due to a lot of social stressors as well. So certainly, depression is probably one of the most significant presentations that I see at work. And, you know, again, we've all been depressed at some point. But it becomes a significant problem when it's felt nearly every day, most of the day, when it affects your sleep and that you sleep too much or you sleep too little, Your appetite is impacted in some way. You lose your interest in things kind of wanes, and anxiety is increased, and all a host of things. Feelings of low self-worth, difficulty concentrating and focusing. So again, that's something that is pretty common, but when it's, again, felt consistently throughout the day or the week, it becomes a significant problem. And then suicide is a piece of that too. Suicidal ideation is a problem, and it's certainly something that is something I see in my work a lot on a daily basis. Isolation, when folks tend to not want to really venture outside of their home and they spend a lot of time in bed, or there's little interest in going out, they kind of lose the desire to be active. And what Dr. Arnold was talking about, it kind of improves our mental health to be active, to socialize. So when you isolate, it kind of negates that and increases the likelihood for some of the things that he talked about. I don't know. You want to pick up there?
Okay, so we're just kind of outlining. We have issues like memory problem, fear and anxieties, anger, depression, suicide, isolation, issues of survivor's guilt. So we wanted to kind of talk a minute about what are some of the things that you can do, either as a friend of someone or as a caretaker or as a person in that person's life. Like, what are some of the things that you can do? And so maybe we'll go through some of the issues that we highlighted and talk about ways to kind of be therapeutic in a person's life. So for example, memory problems. You might see someone forgetting names or, as Dr. Arnold mentioned, maybe where objects are in the home, like, oh, I can't locate my keys, or, I forget where a certain object is kept. So we wanted to think about that in terms of, well, what are friends or people and allies able to do about that? And some of the strategies that we've come up with that have found to be somewhat successful are, things like keeping house keys in the same place, or having little markers on things that will prompt someone's memory, photographs with names on them. Does anybody else have an idea of something that has worked for them in terms of helping someone with a memory problem?
They've forgotten them. Maybe.
Postits.
Post-its. Yeah.
Post everything you can.
Yeah.
So you don't have to remember, you can just read it.
Absolutely. Yeah.
I used to, when I did HIV treatment, I used to tell folks to put your medication that you needed to take in the morning, put it on the toilet. When you got it in the morning, the first thing you did was go to the bathroom, you go home and you take it.
Absolutely. Absolutely.
I put everything in Google Calendar, which is new, I know, but then it can send you a text, like at
Oh, that's a great idea.
You're supposed
Yeah.
to do it. When you're remembering it, you can set this up if you're in the habit of doing that.
Yeah.
And then I just get these texts, I go, oh yeah, right,
Uh-huh.
that works.
That's a good idea.
I actually use my screensaver as a calendar, so every time every time I turn the computer on, the screen is actually my calendar, and it says exactly what I'm supposed to do today.
Exactly.
That's a great idea too.
When I have a lot of things that I need to do, and I feel like I'm not getting anywhere, I make a list of all the things that I need to do, and then as I get them finished, I cross them off, and I get a sense of accomplishment.
Mm-hmm.
I feel better about it.
Yeah. It's very satisfying to cross those out. Yeah.
See, these are all great ideas. There's someone else back there?
Since I do not have a computer at home, we still do it the old way. We write it right on the calendar
Uh-huh.
and look at it every day.
Yep.
So the doctor's appointments could be months ahead. And that day, we look at the calendar every morning. We say, okay, we got to go do this, 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 and this. So we still do it the old way.
That's great. And there's a lot of creativity in the room. And the other, some other.
I was going to say, and this is the old way, I am really a nag, and it works. I take care of my brother and I nag him to death.
Uh-huh. Sure.
You often use that.
And I think what we can take from this is that there's no one right way of doing things, that there's a lot of creativity in the room and that people have different ideas, and you have to really tailor what's going to work for the person. And to be patient, because sometimes not every method works for everybody. So if something isn't working, not to give up with it, to kind of go on and try to find the next thing that would be effective.
I find the journal writing can be helpful. Very much.
Absolutely.
I also think normalizing it, you know, for the caretakers, if they can normalize the memory problems so that they don't seem so mysterious or strange, or it's only happening to me, you know, that kind of thing I think can help as well. That it's not unusual, it's not out of the norm. So
Is that where a support group might come in handy, or can you talk about, or you and Judy talk about how therapy or talking to someone who's trained, such as yourself, in social work and counseling can help with some of the issues around aging, maybe in general?
Sure. And I think that we've talked a little bit about it this morning. Dr. Arnold brought up the idea of social connectedness, that to be connected to other people. Sometimes those are friends or people we have in our lives. Other times we want to seek out a professional for support with that. But it is really important to get out whatever you're feeling. Sometimes, you know, again, it presents in many different ways. It could be depression, could be anxiety, could be fearfulness, or just, you know, like a desire to communicate. But it's important to reach out for help in some way. And again, that there's no one right way to do it. Sometimes for people, it's support groups. Sometimes it's, you know, forming, you know, like a group of friends to get together and talk about things on a regular basis. Sometimes it is professional support.
yeah, and certainly something that I talk about with my clients is always to be active, be in a support group, or be part of a church or something social that kind of connects them with somebody else. I think connectivity is really an important part of getting older and staying. Yeah, I think if you feel like you're a part of a community, it's always going to help you in some way, mentally and physically. So that's something that, you know, that I talk about a lot. Support groups, certainly. I know that, you know, when I recommend things, I always think of William Way's support groups that they have, the social groups that they have. So those kinds of things are always things that I suggest. So, yeah.
I'll just make another comment. In terms of your role as a caregiver, so if you're providing care for someone whose mind is aging and dementia or Alzheimer's, that it's really important to take care of yourself as a caregiver. And we'll talk about that in a few minutes with our caregivers, but maybe Judy and Rand, you can speak to that as well.
Yeah, certainly that's something that I, as a therapist, deal with all the time. I mean, I hear some pretty difficult things, and so I think it's important for us to be active as well and be social and do a lot of the things that we tell our clients to do. I think exercise and hobbies and staying connected with friends are things that I do and I recommend to other caregivers to do to help with the stress of being a caregiver. So, yeah.
And I think one of the most important things that you do for someone, whether it's a friend or a partner, or someone who's dealing with, whether it's an issue of an aging mind or just, you know, some other kind of psychological distress, probably the most important thing you can do is just be there and hear the person and listen to the person and offer support. Just by doing that, it is probably more therapeutic than you might imagine. So again, like being there and then having someone where you can talk to and, you know, share those feelings with someone else as well to take care of yourself.
There should be a caregiver support group. If there's not, there should be. That would be a good thing to have.
Yeah.
Maybe there is. I don't know. But.
That's right. And hence the reason for the survey, right? Because we want to find out if people in our community, first of all, need a support group, which we think we could all use support groups, but we want to make sure. And then around that support group, what do you need from a support group in terms of being a caregiver? So all those are in the survey. And that's another plug for the survey in case you didn't get that. Anything else?
I think we would kind of like to open it up to your questions and to hear what ideas or questions you might have or want to know from us or our experience. So,
I wanted to comment on a comment that you made with regard to disclosure to physicians, nurses, primary providers about one's sexuality, who one's partner is, etc. And I'll reference this a little bit when I speak on the last panel about caregiving. I'm a nurse, and I feel very, very strongly that it's critical for the provider to know who you are, where you're coming from, and who the person is who's going to be speaking for you on your behalf. And if there's some reason why the provider that you're seeing is not comfortable with that, to find another provider. Luckily, we live in Philadelphia. I would say in my 30, 40-year experience as a nurse, I haven't witnessed, at least in my own practices, a lot of hostility within the clinical situation, but we don't always know. And that's a more difficult situation to deal with than actually knowing what's going on. So I would encourage you in your own practice to help people deal with that. It's just critically important for the provider to know and for the provider to be sympathetic, and when he or she isn't, to get out of that provider relationship.
Absolutely. Great
I think that's very true, but I think sometimes some folks don't have access to care.
And that's
That-
a whole other problem.
You know, they don't live in Philly, or they live in an area that they don't have the supportive care network that they need, and so it's a tremendous problem.
And we often hear from people who've gone to mainstream providers that they haven't felt supported, and maybe there was not something that was overt that happened to them, but things that were more subtle forms of discrimination, or presuming to know something about the person. So.
Now, I'm hearing that you have an open door policy for people to come. Does it matter if they have other facilities that they can get care? Like, I have a primary care physician that, actually he is gay, lucky for me. But I have other physicians too who know about me, because I'm just very open about it. I don't hide it from them. If they have a problem with it, then I would need to change physician. You know, you can't be sensitive to it, I need to go. But what I'm saying is, could somebody who has these other things, could they still come to your facility for information and questions and
Sure. Absolutely.
Care and whatever?
Absolutely. And there are people who, you know, see doctors elsewhere, who come in to Open Door for therapy, and or vice versa, people who use the health center who go elsewhere for care. So there's no requirement that you get services in there. Yep.
Steve, did you have a question?
I do. I think the concept of supporting someone's a balance for independence, and sort of the guilt of realizing that at some point someone's the capacity to make informed decisions and trying to support their independence, but at some point where it becomes a safety factor, and trying to allow someone to be as independent as possible, and then just that balance between, you know, again, capacity, taking some, you know, all the things that people need in life to remain independent, whether they're LGBT or not. You know, whether it's taking away a driver's license, or safety in a kitchen, or any of those things that as a caregiver you know you want to try to support someone's independence as long as possible, but it becomes a real struggle of when you make those decisions. Do you find that a lot in your practice?
Not so, well, no, that's not true. I think there have been occasions where I felt that the individual needed something more than they were currently receiving. And at that point, I feel like their physician needs to be contacted, and there needs to be more care around that individual that I can provide, so more of a group care, I guess. So, but yeah, that's certainly something that I've encountered, and it's challenging though, because you're asking somebody to really consider their ability to live independently and take care of themselves, and then a lot of the concerns that we've talked about, depression and all of that, they spike, and it becomes very challenging. So yeah.
It is a very sad moment where that person who really, you know, wants to remain independent has lost the ability to do that, and you know, it is heartbreaking. But I think that we're fortunate as well that there are a lot of great resources around and great advocates to help identify, you know, turning some challenge into actually maybe a new opportunity, or a new opportunity to do something. So while, you know, a person may not be able to drive anymore, but they are linked with this new transportation system that still keeps them active. So there's a way to not make the situation worse where the person then becomes isolated. So all that said, that there are, great resources out there, and that people, that, through different area, resources on aging, or different, like care management groups, or even through insurance companies, can help get like some either supportive devices or supportive advocates involved in a person's life. And I'm sure that we'll kind of get into that more in caretaking.
Elaine?
I just want to say one thing, that in some groups, as friends, it's almost your responsibility. I mean, we want to be as supportive to people that are having issues, but for example, nobody wants to admit that they have Alzheimer's, and there's a lot of resistance with that. But as a friend, you might see them declining, and it would be helpful for you to say, you need to go to a doctor and find out what's wrong. I mean, a lot of people don't want to talk about those kind of things, but if someone's living alone, we want everyone to be safe. And I think that's what we're always encouraging with the Alzheimer's Association is talk about it. If you're seeing changes in your friends or your family, talk about it. Find out what's going on, as opposed to just pretending that they're okay, which a lot of people do for way too long.
Yeah, I think that speaks to how the society looks at depression and Alzheimer's and all of these concerns. And I think if we can kind of shatter that idea of it being something ugly or bad or whatever, and just a fact of life, I think it'll be easier to have these conversations and put it out in the open.
We have time for one more question. Peter?
I've recently come to understand the real benefits of working with a licensed clinical social worker and having them operate on in a multimodal way with my other care providers. So in other words, I could have a long, affordable conversation with that person, and they would be able to contact it. I set this network up and keep everybody in the same line of communication. It really seemed to help me take control of potential diabetes and other health issues that I was trying to reduce before I became 65 or older. So my question is, the role of a licensed clinical social worker as a care coordinator in general, because I noticed with my mother, who's in her late 70s, she's very overwhelmed with all the different people she has to contact. She loses track of them and misses appointments. And all these things are interrelated. So as we go forward, moving into a more integrated healthcare plan, sort of more like how cancer is currently managed, but for the rest of healthcare, it looks as if Alzheimer's is another particular candidate, or memory loss as you get older is another candidate similar to cancer that would really benefit from an integrated care plan. It would seem to me that a licensed clinical social worker would be the key point person. Do you see any movement towards this and towards developing a care plan that maybe lasts for 5 or 10 or 15 years?
Yeah, I think that I can say like maybe 10 years ago, 15 years ago, it was kind of the scenario that you were talking about, that everything was kind of fractured. Well, you would go here for this, and this go here, and then this person did this, and then you saw your doctor. Most medical settings now have a more, as you said, integrated approach to that, where either like maybe a nurse navigator or a social worker kind of takes the lead in coordinating all the aspects of a person's care. And I definitely think that that is where medicine and social services are going and growing.
I think there are more agencies like Mazzoni and the sister agency in Boston that are popping up across the country and on the West Coast as well, that kind of take that model and of an integrative approach. So yeah, I think it's happening more and more.
Excuse me, can I make an announcement?
Yes, you certainly can, and that will be our final question before
Just
we move
an
on.
announcement. Right here, right back there, we've been here for 10 years, a free peer-run support group called the Pink and Blues. There are business cards around the tables, and we meet every Wednesday from 7 to 9 in the Blue Room, and it's free, and it's peer-run in that we're experts in our own minds, bodies, and spirits. We also are a network outside the group of people that do social things and share and help each other. And so everyone is welcome on Wednesday from 7 to 9. I'd like to ask one thing for the future, that we address suicide prevention. We have the Trevor Project for youth, and we don't have resources for adults and older adults because it's a very pressing issue that's in the closet in our community.
Over 60 is the highest rate of suicidality in the U.S. Absolutely.
Sounds like a next topic for our LGBTEI conversation. Okay. So thank you, Judy. Thank you, Rand. We're going to reassemble our next panel. Well, not reassemble, assemble our next panel. So take a minute, use the restroom, grab some more food, and we'll be back in about 2 or 3 minutes.